marketing is so good, they can overcome almost all problems. Like, that's really no problem. We can sell a weaker, much more expensive drug very, very easily and replace the older, cheaper drugs quite simply. So what they're tremendously good at is propaganda, selling things, marketing things. Clinics call us in and give us problems we didn't know we had.
When I first read this book, Let Them Eat Prozac, I must admit it gave me so many sleepless nights. I could not believe I was part of an industry that was actually doing this.
The people who've helped me most in the work I've done have been people working in the pharmaceutical industry. They were the ones who leaked documents or told me about things that I needed to know. The people who've been least helpful have been my clinical colleagues. Even with really good RCTs done by angels, which the pharmaceutical company trials aren't always done by angels, RCTs, they only give you an average, and they don't tell me how to treat you, for instance, if you came in to see me.
The higher dose, the better. The longer the prescription, the better. So
let's double the dose. Not only that, but from an industry point of view, it's good if you get hooked. English has a problem. In French, the word evidence means what's obvious right in front of you. In English, evidence often is we're going to persuade you not to believe the evidence of your own eyes. When people actually die from suicide, for instance, we should have a record of all the pills that they were on, but nobody actually collects that. People in this world who do the most research and the best research are women who are pregnant or are thinking about becoming pregnant.
Namaskar, welcome to the Anulal Show. Today we'll be speaking to Dr. David Healy, who's a doctor, a psychiatrist, a psychopharmacologist, scientist, author, and professor. He has published over 200 peer-reviewed papers, written 200 articles, 24 books, including the antidepressant era, one of my favorites, which is Let Them Eat Prozac, and the recent one, Pharmageddon. Dr. Healy serves as an expert witness in legal cases in violence, homicide, and suicide involving psychotropic drugs. He's a strong critic how pharmaceutical companies have created markets for medicines and they shape disease to market their drugs. He has founded an online platform called Risk, which is a logging platform for patients reporting symptoms and side effects which are not really documented in the clinical trials. Now, we cannot cover the entire body of his huge work, but we'll try and focus on a few aspects, which is, of course, firstly, where is evidence in evidence-based medicine? I would like to know more about the Risk platform also. The interplay between pharma and academia, can we really trust the written word? And of course, I would like to start with violence and antidepressants. When I first read this book, Let Them Eat Prozac, I must admit it gave me so many sleepless nights. I could not believe I was part of an industry that was actually doing this. And we believed we were saving the world. And I never thought that one day, David, that I'll be really speaking to you. This is such an honor. It is such an honor to have you here. Thank you so much for joining in.
Okay. Well, I should add quickly into this that the people who've helped me most in the work I've done have been people working in the pharmaceutical industry. They were the ones who leaked documents or told me about things that I needed to know. The people who've been least helpful have been my clinical colleagues.
And please do tell us that sales and marketing people have been helpful to you too. That is my breed. This is something which I think I've also seen because, people who are on the ground, they are packed with so much information that, we take that information to the ground. We really believe we are the superheroes. We are saving the world. And then we are the first people to hear back from the market also. And often when we relay that information back, nobody listens to us.
Yeah, sure. No, sure, it's true. But I guess the industry believes that their marketing is so good, they can overcome almost all problems. Like the SSRI group of drugs, of which Prozac is the one that people knew first, I guess, came out and they were weaker drugs than the older antidepressants. So I was curious because at that point I had lots of contacts with people in the industry and their view was, well, that's really no problem. We can sell a weaker, much more expensive drug very, very easily and replace the older, cheaper drugs quite simply. So if they can do that, they can also hide the problems. And in particular, for a condition like a mood disorder, which can cause a whole bunch of problems, people become suicidal or homicidal or have problems trying to make love or being fatigued or just the opposite, unable to sleep. All of these things, if the pills cause them too, well, it's easy for industry to say, that was just your illness.
It has nothing to do with the drug, yeah.
Exactly.
Which is kind of so sad. And what interests me a lot, especially in this book and otherwise in your work also, was the intersection of law and medicine. Do psychotropic drugs promote violence and suicide? Your book has evidence which is absolutely clinching. Was this never studied before, or did the pharma companies actually hid this? How did you start working on it?
Yeah, sure. No. It actually had been known since the first antidepressants came out in the late 1950s. By 1959, about a year or two after they came out, there were the first doctors using these drugs have begun to report back. Well, they're great, they're wonderful. This is really helpful. They get people out of hospital and things like this. But they can also cause some people to commit suicide, and they can cause some people to become violent. Not the common thing, but it can happen. Okay. Now that was well known for 30 years or so before we got the SSRI group of drugs. Selective serotonin reuptake inhibiting antidepressants. And the interesting thing was when the same thing began to be reported with them, when doctors began to report some people had become suicidal taking Prozac or had become violent, industry had an interesting response, which was, well, we've analyzed our clinical trials, and the clinical trials show that our drug doesn't cause this. So if this Dr. Healy, for instance, thinks he's given our drug to a person that he's been treating and she or he became violent or maybe became suicidal, well, he's just made a mistake. That's an anecdote. It's what we call misinformation these days. Problem is this. If, say, for instance, I'm in the jury, any people listening here are in the jury for a murder trial. A man has murdered his wife, and his lawyer says to the jury, well, we've done a randomized controlled trial, and on average, men, even when they've got a criminal record, even when they're in legal trouble and financial trouble, even when they've got wives that no one likes, on average, they don't murder their wives. Therefore, you cannot say that this man has murdered his wife. Well, the jury would say, that's crazy, we don't care about the science, as you call it. We're going to judge this case on its merits, the facts of this case, and if the evidence in this case says the most likely thing that happened was he did murder his wife, we're going to find him guilty. So that's the same thing as clinical practice. But a lot of doctors were told that, well, your thoughts about what's happening to your patient are just anecdotal. You can only believe what we, the company, tell you our drug does. That argument shouldn't have won, but it did.
So that kind of brings up random controlled trials. I mean, I'm not a clinician. I would be shooting above my pay grade talking about it. But as a lay person, you've spoken a lot about random controlled trials not being the gold standard as they are perceived. And it's the pharma industry that has really been marketing them as a tool which the doctors quote that, it is an RCT and that is why it should be believed. How do you respond to that?
Well, the one way to respond is that the person who created the first randomized controlled trial, a man called Austin Bradford Hill in the UK, said, well, it's helpful to have RCTs, but the best way to know what a drug has done to a patient is to talk to the patient, ask them, look at them, listen to them. And, he said, even with really good RCTs done by angels, which the pharmaceutical company trials aren't always done by angels, okay? Even with really good RCTs, they only give you an average. And they don't tell me how to treat you, for instance, if you came in to see me. I've got to listen to you. First of all, I have to let you know all the things that I know about the drug. I have to let you know as well, we're going to be giving you a poison, and what we're trying to do is to bring good out of the use of a poison. And I need to remember that, and you need to remember it, and I need to listen closely to you, if you're on this pill, about what you say, because you're the best person to tell the world what's happening to you on this pill. Now, sometimes maybe you aren't the very best. Sometimes your family can spot things happening to you that you may miss. You may feel great. They may think, gosh, she's too great. She's had a change of personality. We need things that people you live with can spot. For instance, let me explain to you. I have a great story. 25 years ago, with a bunch of colleagues, we did a randomized controlled trial. We thought we'd get a bunch of doctors and nurses working in the mental health unit that I was in to take part in a clinical trial comparing either an SSRI antidepressant and an antidepressant that didn't work on the serotonin system at all, because the way the SSRIs were actually discovered was a man called Arvid Carlson listened to doctors talking about the older drugs and realized some of the drugs that worked on the serotonin system were doing something interesting. They were making people a little less anxious. So he said, let's get a pure serotonin reuptake inhibiting drug and see how that does. So I thought, well, let's see if we can get a bunch of doctors, nurses who are blind to what they're on. They don't know if it's an SSRI or a non-SSRI that they're on, okay? And let's see if they can tell the difference between the two drugs and put in words what it is the SSRI does that maybe helps them, okay? So we were able to find out that actually Arvid Carlson was right. There is this anxiolytic thing that an SSRI does that the other antidepressants don't do. But we kept the doctors and nurses on each of the two pills for 2 weeks. They had one or the other for 2 weeks, then 2 weeks free of drugs, and then they had the other one they hadn't had before. And the interesting thing was, 2 days after we began, the patients in the ward, none of whom knew anyone was going to be on these pills, okay? One of them came up to me and said, is that doctor on a pill? And is he on an SSRI? Now, at that stage, it was blind and I didn't know, but when we opened the blind, the patient was right. They can spot what's happening to people. They can spot what's happening to the other patients on the ward the way the nursing staff and doctors can't. We used to be able to see what the drugs did to people, but because we now believe the randomized controlled trial, which say these drugs maybe don't work for 3, 4, 5, 6 weeks. Well, actually, the patients knew they work within 24 to 48 hours, and you can see what they're doing, whether it's helping you or not helping you. And of course, if it isn't helping you, you shouldn't continue with it for 3, 4, 5, 6 weeks.
Essentially, it's also breaking the blind.
Well, I know, but you see, the thing is, it's breaking the blind's not too important. The important thing is if we take a group of people and see, on average, does this drug help? At the end of maybe 6 weeks, on average, is there something happening there which means this drug could be useful? And it can be useful if I give it to you and you say, yes, I can feel what it's doing for me, and this feels helpful. It's not going to be useful if I give it to you and you feel more agitated and having strange thoughts that you haven't ever had before. You should not continue with it. But what happens is you often come back to the doctor like me who says, oh, well, you must have been more ill than we thought. Let's double the dose. Yeah, which is a big problem.
Well, it increases sales. It's not a problem from where I come from.
From the industry point of view, no, it's not a problem. Sure. Yeah.
Sure. The higher dose, the better. The longer the prescription, the better. So if something's not working in 24 hours, if you change it, then, that's a problem because you may as well try it for 3-4 weeks. That's the problem. It's going to take that much long because the trial said that.
Not only that, but from an industry point of view, it's good if you get hooked.
Absolutely.
Yeah.
Absolutely. It's the addictions which we are selling after a point of time. We do realize that we're selling addictions, and in a lot of therapy areas, not just this, but also painkillers. And
yes, of course.
And it's been disastrous. So that's pretty sad. From here, then, you are documenting on risk the individual experiences that what people are reporting like this. And do you see a lot of cases where people tell you information which is not there that the drug companies say? How has the risk platform evolved?
Well, there's 2 or 3 things there. First of all, before I got into all this, before I began to practice clinically, I worked on the serotonin system, on the effect of antidepressants on the serotonin system before we had the SSRI group of drugs. Mm-hmm. So that meant industry were quite keen to have me as one of the people who would talk to other doctors to explain these drugs to them, okay? Which meant industry, in a sense, thought I was one of them, and we're happy to chat about our drugs really are actually quite weak, but the marketing department will make sure they sell, etc., okay? But, yeah, I've been working with these drugs for 40 years, but every time I actually see a patient, people report things into this literally every week. I find out things about these drugs that I didn't know before. I mean, I know a lot of things that aren't in the drug label, but literally the people that come and report things to me tell me things the whole time, even now, 40 years later, things that I didn't know and that nobody really knows, that they aren't in the literature yet. And part of the problem with them not being in the academic literature is journals have got very nervous about publishing problems that drugs cause. They're told by their lawyers, well, if it's just a case report, if it's just an anecdote, if it's just misinformation, if the clinical trials haven't shown this, the pharmaceutical company might sue us if you publish it. So it's got harder and harder to get journals to take reports about what pills do, which is how we make a breakthrough. You know, it's the individual case or the case that's atypical that will often tell us more about how the drug works and tell us things that may open the door to new drugs. Like probably the most famous case was when people were in a clinical trial for Viagra for cardiac problems, and some of the men said, well, it hasn't helped my heart, but it's doing other interesting things.
Stuff down there.
Yeah.
Right. Interestingly, when Viagra when Viagra came off the patent, I had come back to India. So when Viagra came off patent, I was in India and the generic version was being launched and I was part of the launch team. Again, doing technology support for the sales and marketing of the team. And yeah, it was a big joke how the drug had evolved, but then it became such a blockbuster. Everybody was vying for the patent to come off, and companies in India were ready to launch it even before. Like it was like time was ticking. Let the patent go off and we'll launch it. It was such a big blockbuster.
Yep.
So when you speak about the risk platform, why it interests me so much is that it's almost in the domain of personalized medicine or personalized prescription in that sense, that moving away from the average, going into personalization. And in Indian philosophy, we have something called pratyaksha praman, which is evidence that you can see, which is there in front of you, which you cannot ignore. This is not a reductionist way of looking at evidence, but it is something which is reported directly, experientially, and that should not be lost.
Yeah. And you're right. And the interesting thing about it is that English has a problem, and French doesn't have the same problem. In French, the word evidence means what's obvious right in front of you. English evidence often is we're going to persuade you not to believe the evidence of your own eyes. Mm-hmm. Now, one of the interesting things about risk, which actually comes back to the point you just made, was we thought there was a group of people who are actually behind risk thought, we will, it's awfully hard for people to talk about the problems the drug is causing them to their doctor who put them on the drug hoping to help them. Okay? So we thought, let's try and make it a bit easier for them. They'll fill up a report, which they can print off, and it gives them a score, which indicates, yes, it's highly likely your drug has caused the problem you think it's caused, or it's maybe possible. No, we don't think it's caused it. Okay, so this is what the report asks you is the kinds of questions an expert would ask you in order to try and work out, is this drug causing that problem in this person? So we thought, armed with a report and with a score on it, that it will be easier to go and talk to your doctor. But the surprise was while we've got thousands of reports, thousands of people have come in and filled up these reports and told us things that we just didn't know before, okay, they still feel too nervous to take the report to the doctor. Because a lot of them, even when they've got nice doctors, suspect the doctor will become angry. And they're right. doctors can become quite nasty. We often think, well, at least doctors think they're the good guys. And the industry, the pharmaceutical industry, they're the bad guys. But in fact, as I've actually said to you, I've had more help from people within the pharmaceutical industry than from my clinical colleagues who, even with me, when I talk about the problems drugs can cause, get nasty with me. I mean, it isn't just the patients, it's me as well.
It's possibly so much of brainwashing that happens from the industry that somewhere along the line, possibly science has forgotten to be science. It has become the pharma-oriented science rather than science which is supposed to search for truth. And
absolutely.
come up with the real genuine stuff. It's motivated science. Unless I can profit from it, it's not science.
Yeah, sure. Well, the best kind of science is really what happens in a jury trial. You're getting a bunch of people who have different points of view, who are asked to look at what's happening right in front of them and come to a consensus about the best way to explain it. That's what we should be doing when we're actually doing science. And that's what happens when you, for instance, come in to see me and reporting back something that's happened to you on this pill. You may think it's called, the pill is doing it because it's doing this. And I might think, well, maybe it's doing that. But between us, we should be able to come to a consensus. And then we can share that I can share it with other colleagues and see, have they seen the same thing when they give this drug to other people? And you can go online and see what other people who are on the pill are actually saying. So that should be the way things work, rather than being told, well, you're just dealing in misinformation.
Since when did truth become misinformation?
Well, yes, exactly.
In that sense, you've spoken about medicine history being part of suicide conversations and conversations about violence. And I believe some states in the US now have passed laws where it's mandatory to check for history of medicine that the person's been on when they indulge in a crime.
I haven't heard that. That's the kind of thing that should be happening. It's the kind of thing when people actually die from suicide, for instance. We should have a record of all the pills that they were on, but nobody actually collects that. We should have registries when people get pregnant, for instance, so all the women involved can report everything that they were on, and we can see what the outcome is, both for the woman, her health, for the baby afterwards. And, that's not a controlled trial. It will produce a huge amount of information that people have to work through. But the people in this world who do the most research and the best research are women who are pregnant or are thinking about becoming pregnant. And I've got great confidence in their ability to weigh the risks up and to know when it's reasonable to take a risk. I mean, they don't just get scared, weigh things up, and usually make a very good judgment call about, yes, it's worthwhile in this case to take a risk. Things could go wrong, but, all things being equal, I think I'm going to go ahead. So we should have a lot more registries like that people can consult. And it's so easy these days when you record on the computer everything the person's done the whole way through the pregnancy, or through, before they actually go on to commit suicide and things like that. You have a good record of all the things that they've been on. And if we just compiled all of that, we'd have a good indication of what pills may be causing a problem, or what pill interacting with other pills could be causing a problem.
That is a subject of a totally, much larger discussion, right? Nobody's checking for the cocktail of pills that people are on, which is interacting with whom, what effect is one happening on the other. I think that's way, way beyond a trial. Even the scope of a trial, it's not possible. That has to come from real world evidence.
Well, here's a point for you, which will be interesting. Hopefully, one of the big things we've had now, because the industry has been so good at being able to market their pills, is we've got polypharmacy, which we didn't have till roughly 20 years ago. The word was only created roughly 20 years ago. And then it was thought if you're on 3 or more pills, that's polypharmacy. But now there are people on 10, that even teenagers who are taking 10 psychotropic drugs. So it's a huge amount in the United States, absolutely, in the United States in particular. But here's the thing. If I'm trying to help you get off some of these drugs, now, by that I don't mean helping you withdraw. I'm saying if we're trying to reduce the number of drugs you're on down from 10 pills to maybe 5, or ideally 3. There's no randomized control trial that's ever going to tell any doctor or you what the best way to do this is. I have to work closely with you. You're the one who's going to know when I tried to stop that before I had problems. So, we need to work around that. And the path that you take to get off all these pills, the path that we take to get you off all these pills, is going to be very different from person to person. Sticking to too rigid a rule will kill people.
True. Very, very true. I mean, I've been following Dr. Joseph for a long while now, who runs the Taper Off Clinic in the US, and he talks a lot about having these effects and these interactive effects of medications. But again, it's going into the clinician's domain, but purely coming from a legal and a marketing point. If doctors are able to do that, the spotlight is then back on the doctors and not really on the trial and the marketing. All marketing efforts can fail. And all of doctoring of data, I think it's in one of your books, I think this one, where you have a whole chapter on doctoring of data. So if the spotlight shifts to the doctor's chamber and doctors become real doctors, then this doctoring of data will be of no use.
Sure. And that's the kind of thing doctors need to realize, because if the pills work so well as they're being told, and are so free of problems as they're being told, nurses and pharmacists are cheaper prescribers. Who needs doctors? And that's actually happening in the United States and elsewhere. Expensive doctors are going out of business. And the only thing that gets doctors to listen to the message is, well, you risk going out of business if you don't agree that the drugs can cause problems, and it needs an expert to handle these problems.
So if expensive doctors are going out of business, then AI can replace such doctors so easily. That's why you need a doctor who understands the personalized aspect of dealing with patients, which means that a doctor has to spend more than 15 minutes with a client.
Yeah, sure. No, sure. But it isn't just purely time, because lots of doctors maybe only see you for 10, 15 minutes, but they see you. I mean, you've got to have continuity of care. You've got to see the same doctor. An idea a doctor that you get on with. The important thing is not evidence-based medicine, it's relationship-based medicine. You've got to be going to a person that you can trust to look at you closely, listen to you, and believe you, not disbelieve you. Sure, there's some people who try and fool the doctor and things like that, but when people come along with a problem, for the most part, they're going to tell you the truth, because medicine won't work unless they do tell you the truth and you believe them. And the problem we've got at the moment is medicine really isn't working. Life expectancies in at the Western world are all falling. The reproductive replacement rate is falling. We've got a whole bunch of problems linked to the increasing use of all the pills that we're on. Yeah, I mean, doctors need to wake up and smell the coffee, as it were.
Wow. I wanted to ask you something. I had parked this question for the latter half of the discussion, but I think the time is now opportune. In India, we are following the Western mental health model blindly. We are blindly copying it, and especially the American model. Do you think we should be worried and we should not be doing that in some way? Because we've seen where this has gone, and importing it directly without any caution, without any thought, may cause a lot of problems, may actually lead us to the same place where I think 1 in 6 Americans takes a long-term psychotropic drug, and not just one, maybe a combination of 2 or 3.
Yeah, no, I'm sure you're right. One of the ways it occurred to me to maybe tell people what the issues are is that, broadly speaking, the United States hasn't been particularly good at discovering new pills. What they're tremendously good at is propaganda. Telling things, marketing things. That's the kind of thing that you need to be aware of, that yes, propaganda from the United States, from Levi jeans through to the pills, is the kind of stuff that has worked awfully well, and it's not always the best product that you're getting. They can sell anything. So, I think people need to remember that and try and hang on to their old way of seeing things and figure that, there is wisdom there that we don't want to lose.
Interesting. So the model needs reformation there also, and we can learn a lot of stuff rather than a blind import, is what I hear you
Oh,
saying.
absolutely. Yes, sure. No. The key thing is that you need to treat the person in front of you. That means treating, I mean, and it means both for the person right in front of you, but also for you when you come to see me. You need to relate to me, and both of us need to know the way we're thinking generally. We need to know what's happening in the community in which you live, as opposed to what's happening over in the United States. And we need to mobilize people in the community in which you live to help shed light on the things that may be happening when people go on these different pills.
David, that fundamentally changes the paradigm of what we are talking, in the sense that we are again moving back to the family kind of clinic, the family doctor domain, rather than the big fancy hospitals where multi-speciality domains, you meet one doctor and then the next time you may meet a different doctor. And here what we're saying is that no, you need continuity of care, and person needs to know you over time. Isn't that like going back in time where we came from?
Well, it's also maybe going forward, because if you ask what we're doing when we do science, people have the idea that we're trying to be universal, and there'll be a truth that's going to be true for the United States and India, just as true for India, but it's not. From the genes in you and me that we look at, we want to know about every single individual gene and what it does. So we don't assume all genes do the same thing. When we look at it, the universe, we don't just want to see galaxies. We want to get hold of every individual star in order to work out what's going on. And it's the same with people. This is something that I learned very early on, before I actually became a doctor. I was in a pharmacology practical, and I was paired off with this lady, and the idea was, I'd give her a beta blocker, and she'd give me one, and we checked our heart rate afterwards. And one of the most solid findings in all of medicine is that beta blocker drugs slow your heart rate. And I behaved normally. My heart rate slowed. But she felt a bit anxious 10 or 15 minutes after she had the pill. Mm-hmm. And we checked her heart rate, and it had speeded up. Mm-hmm. So this brought home to me, in real life, what's happening is what you can see happening right in front of you. It's not what's in the book. The book may be helpful, but what's actually happening when you give a pill is what's actually happening to the person right in front of you. So, yeah.
Wow. So I'm hearing personalization, personalized medicine a lot more. I think that's the very strong message that you're giving out.
Yes, and I think that's the only way to keep people safe. If you're just operating according to the book, and if you take the case of the lady that I gave the beta blocker to, her heart rate speeds up. So the book would say, well, just increase the dose of the beta blocker, so that isn't going to be the answer. You've got to be able to adjust the situation that you're actually dealing with. And that's both of us. I mean, if you find he isn't understanding this, you've got to think a little bit more about, how do I explain it to him? And maybe you recruit friends and things like that, or whatever, to
so then
make sure that I'm able to.
Where does this lead? The big journals who are publishing these big studies. I mean, you were anyway saying at a lot of places that these are ghost written articles. They are written by the industry. But even if they are not written by the industry, where does this leave all of that writing work?
Yeah, part of the problem is, even if they aren't written by the industry, even if they're randomized control trials and done by angels, they only tell us averages. And the interesting thing really is what's happening to the individuals and why you're responding differently to me. This is the way to find out what actually makes humans humans. Human body is interesting. I mean, it's you might have a raised blood pressure a bit and things like that. And if it's not much raised, well, yours is a bit higher than mine. Your body and my body work out how to handle these things. It's not just blood pressures. It's, they fit in with everything else, like your heart rate and this, that, and the other. And it's how the body overall is actually coping. So we need to keep an eye on the fact that, well, maybe you're a little bit raised with your blood pressure, but if we had figures for everything in you as opposed to just figures for your blood pressure. And we might see that overall, your overall figures are actually better than mine. I have perfect blood pressure figures, but overall, yours work better than mine. The problem is if we just measure things and aren't able to measure everything, we get hypnotized by the measurement. And if industry say, oh, well, they're a bit high, those figures, but we have a pill that will bring them back down to the average, that's fine, but you're not seeing what the pill is doing to all the other things. Your body's in balance. Have we disturbed the balance elsewhere? We don't look at that. We just feel, the doctor just feels pleased because your blood pressure is good. Actually, I can maybe tell you a good story here. Back, I think it was an Indian doctor, I'm pretty sure it was, working in Newcastle in the United Kingdom 45 years ago, and there were some beta blocker drugs had come out on the market, and he had run a clinical trial with his wife. She was probably the brains behind it, but they'd run a clinical trial where they gave the beta blocker to 75 men who had raised blood pressure. At that point, we had the old mercury column. You could see the mercury drop when the blood pressure came down. And in 74 of the 75 cases, the man's blood pressure came down and the doctor was happy. In roughly half of the cases, the blood pressure came down and the man was happy, probably because the doctor was happy. 75 of the 75 cases, his wife was unhappy because she said, before you told him he had raised blood pressure, he was relaxed and calm and happy. Before you said your blood pressure's up and it could cause you a stroke and a heart attack and this, that, and the other, he was a happy man. And you've given him side effects from these pills as well. So she could see that things were fine. I mean, I'm sure if you told her his blood pressure's dangerously high, she'd have said to him, look, you need a pill for this. But if it's just mildly up, you're going to make him neurotic by saying you have a condition and it needs treating. And you're also going to give him side effects. So,
So that kind of brings us to the discussion where is over-diagnosis and over-checking of parameters even a good thing? The fact that we can check everything now, is it even a good thing? Does it create too much of stress just by knowing that, oh, this is high, this is low?
Sure. But yes, you're right. We overdiagnose. We also underdiagnose. What we've been talking about up to this is we underdiagnose the adverse effects. So if we completely overdiagnose, we might learn that, well, actually, yes, your blood pressure is a little bit up, but it might not be worth taking these risks. Let me give you a slightly different story, which may be helpful. Albert Carlson was the man who created the SSRI group of drugs. They were his drugs. And actually, if you asked them, yes, these drugs can be helpful, but can they cause people to commit suicide? He said, yes, absolutely, they can. It's a bit like LSD. Some people have a good trip, some people have a bad trip. But he was aware his SSRIs didn't suit all people. One of the conditions that they use for most is to treat people who've got obsessive compulsive disorder. And they work better for people who've got OCD than for people who are depressed. But he found that a group of patients came to him and said, look, we've got OCD and your SSRIs don't suit us. And he said, really? And they said, yes. When we smoke nicotine, it's better for us. So he ran a trial and he agreed with them. Yes, there's a bunch of people SSRIs don't suit and nicotine does a lot better. Now, the only person who can make what we call a risk-benefit assessment is the person who takes the pill. If you're taking an SSRI and it's not helping your OCD and is causing problems, you know what it's doing for you. If you take nicotine and it helps your OCD and isn't causing too many problems, you're the only person who's in a good position to work out what it does. Is it a benefit here that's worth the risks? Now, in the case of nicotine, we all know there are risks for heart attacks, maybe lung cancer and things like that. But the SSRIs shorten your life as well, and you're not told about this. The risks are pretty much the same, but you aren't in a position to work out, is it worthwhile to take these risks? You're not believed when you say, well, they aren't helping me. You just go, well, we need to double the dose.
So then, isn't this a double whammy that we need to have awareness to understand what's happening to us? But then if we had that kind of awareness, we may not need half those drugs anyway.
I'm sure you're right. I mean, I think there is a need. Well, industry make most of the money from giving pills to people who aren't ill. They create risk factors. You know, you've got slightly raised blood pressure or slightly thinning bones, you know, these awful things could happen. Why don't you take our pill? Pick up your bones causes you to be more likely to have a serious fracture. I mean, you aren't told that. To lower your blood pressure, lower your blood glucose and things like this. 99 times out of 100, even if you don't treat it, nothing's going to go wrong. So, you know, we end up on a bunch of pills that we really don't need. Great to have these pills. They can save lives if you give them to people who really need them and keep an eye on things. But if you give them to people who are healthy to begin with, things can only go wrong.
The question is who decides? Who decides what is, if the person is...
Well,
we've taken away confidence of people in their own bodies away, right? So people really don't have the confidence to decide for themselves what is good for me and what may not be good for me. So it brings us to the doctor. And then the doctors are, as we've discussed, brainwashed to a very large extent. And of course, the industry is a profit-making body. It is not there to necessarily heal you. It may heal you. So then the question is, in all these people, who decides? And of course, we've done away with the community. We said, no, everybody's an individual and we don't really need the community feedback. So then who decides?
Well, here's a point. Up till maybe the 1980s, certainly the 1990s, we took problems to the doctor when we had a problem. So it was we who actually decided. But since the 1980s and industry realized we can treat risk factors, we can call it preventive medicine, but it's really treating people who are healthy. Clinics call us in and give us problems we didn't know we had. So that's actually part of the problem we have now. And yes, it's meant that things like polypharmacy have become an enormous problem and are shortening our lives.
I mean, thank God we don't have direct-to-patient ads in India. But when I remember my time in the US, when I used to see those ads on TV, they were advertisements not for medicines, they were advertisements for illness. And then half the time if something would be like, oh my God, maybe I have that. Maybe I should check with a doctor. And as you rightly said, so many people were going in just to check. And the whole idea is to increase the footfall into a doctor's clinics. And we're not going with problems, we're going with perceived problems.
Yeah.
We marketing people have really messed it up a lot.
Well, it's extremely impressive to see how good marketing is. But part of the problem about where you've been able to work, how you've been able to work so well, is that the consumers of the pills are the doctors, not the patient. If the drugs are available on prescription only, I'm the consumer. And doctors are the most naive consumers on earth. There was an old story. I had a friend who used to actually work in the pharmaceutical industry. And he said, you knew that you wouldn't be able to sell pills for ADHD. This is when we only had childhood ADHD. We didn't have adult ADHD where we have it now. But he said you couldn't sell the pills in an area where there were many grandmothers.
Sorry, where there were many?
Many grandmothers.
Oh, okay.
Because, the child might come home from school and the teachers had said, he's a bit overactive and things like that. He's got ADHD, he needs a pill. And, the mother, if she's there on her own, would say, oh, the teachers are saying he needs a pill. But if there's a grandmother there who had seen his father, she'd say, well, he's just like his father was, and his father turned out fine, so no, he doesn't need a pill. So, yeah.
Wow, that is such a powerful thing to say, not just because of mothers and grandmothers, but the fact that now we don't have that generation anymore. I mean, the newer generation of moms has not seen that. They have seen a lot of, especially in the US, the newer generation of moms have seen only medicated kids. So they are not going to be turning out into grandmoms who say that, oh, your father was like this. They're rather going to say that, yes, your father was medicated and you need medicine too.
Sure. Yeah.
Wow, that is such a powerful thing you say.
Yep.
Mm.
I've actually got a close friend who told me a very nice story. He was the quiet, shy type, and his younger brother was boisterous and overactive and things like that. So much so that my friend used to have to do his brother's homework for him, so that, you know, in school he didn't fail and he got through things. My friend is a poor university lecturer. His brother, his younger brother's a billionaire. Mm-hmm. You know, the overactivity and things like that can be a good thing. And you don't want to necessarily damp it down.
No, we kind of can play with a range of human emotions, is what I hear from you.
Well,
and it's normal.
We need a range. If you're playing maybe football, you know, you need the people who can score goals, but you also need the people who can make sure the other team doesn't score goals. You know, we need people with different skills to make a team. If we're all the same, you won't have a good team.
And life is no fun.
Exactly. Yes.
You know what you're saying is actually meshing in with philosophy and messing in. So basically, what you're saying is kind of going well with philosophy and with how the society should be structured, and we are part of that society itself. So we cannot take that aspect away from individual health.
No, I'm sure you're right. And the other thing is we need to realize that the most important people in a society are the women.
Why would you say that?
Well, they're the ones who make the important things that we have in our world. They make other people. And I don't mean just give birth. They make children into people, you know. So that's where human wealth really lies. That's the most important job we have, and women should be paid much more than men.
That's music to my ears. That sounds so good, and that kind of brings us to the domain of, if not women, definitely the feminine. And I love how this discussion is just going so organically that, you know, we've kind of eliminated the feminine out of everything. If I have to succeed, then I have to be like a man. If I have to provide for the family, I have to be like a man. Single woman, single parent. We've kind of redefined the whole structure where possibly the feminine has been under attack. I don't call it women or female under attack, but the feminine qualities per se. Of course, somebody might say that masculinity is also under attack, but the feminine is definitely, seems to me, it's not required by anybody anymore.
Yeah, no, I'm sure you're right. And as I've said, you know, looking at my daughter and her friends when they've been thinking about getting pregnant or are pregnant, they do more and better research than any man would do. But it's not just that. Women generally are probably better doing science. By that I don't mean the gadgets. I mean, your scientific process is about knocking ideas back and forth. You know, you try things out, hear what other people think about what you're actually saying, and you readjust it and things like that. You have conversations. And women do that a lot better than men do. So men get an idea and think, because I'm a man, you know, I must be right. But you're not, okay? And I guess, but of course, we could also blame women, because mothers, when they have sons, tell them the whole time, you're marvelous, you're wonderful. They don't tell their daughters that as much.
I thought that happened only in India.
No.
Okay. Yeah, this has been such a fantastic discussion. I mean, this has been so nice. It's been fun,
all right, yeah.
It's been,